Hello, everyone, and welcome back to Health Reform Beyond the Basics. Thank you so much for taking the time to join us today. We know we have a lot of webinars right now, so we really appreciate you guys taking the time to join us. Most of you have been a part of Beyond the Basics for quite a while, but for those of you who are new, I'm Hallie Cloud, and this is a project of the Center on Budget and Policy Priorities designed to provide training and resources that help explain health coverage options available through the marketplace and through Medicaid. It is aimed at healthcare assisters, advocates, state and local officials, and others who help people get and keep their health coverage. We at the Center are a policy nonprofit in DC. And as a reminder, this series is intended for those working on the implementation of health reform, and it's not intended for press purposes. Today's webinar, which is the third in a four-part series on the core elements of eligibility and enrollment, will provide an overview of health plan design, including cost-sharing charges in the marketplace plans, eligibility for cost-sharing reductions, and how plan design generally affects costs for people enrolling in the plans. We're also going to go into some key things to watch out for with the expansion of non-comprehensive coverage like short-term plans. So with that, I'm going to introduce our presenter today. Sarah Leek is a senior policy analyst here at the Center, and she will take us through plan design today.
Thanks, Hallie. Hi, everybody. So as Hallie mentioned, we have a lot of ground to cover in this presentation today. I'm going to start out talking about the plan design features of ACA marketplace plans and cost sharing kind of parameters for those plans, and also cost sharing reductions that many of your clients and the people that you work with are eligible for. And then we'll spend some time at the end of the presentation talking about non-compliant or skimpy plans that don't meet ACA standards, just so that you can spot them in the wild now that you're probably going to be hearing a lot more about them. So let's start with the ACA plans, which is hopefully what most people are going to be enrolling in. The elements of plan design, we're going to start with some very basic stuff for anybody that has done these webinars before. It's going to be very familiar to you, but we want to start with some of these basics because it's a good refresher with some complicated topics in health insurance. So first, there's premiums and there's cost sharing charges. Premiums are the monthly amount that a person pays for a health plan. And then cost sharing charges are the charges a person pays when they use benefits covered by a health plan. And both of those are things we're gonna, that people are gonna be dealing with when they're thinking about the costs under their plan. We're gonna talk a lot about cost sharing charges today and how they function when people have coverage. So the basic elements of the marketplace plans, we can think about those as divided into what are the covered benefits and what are the cost sharing charges for different types of services. So covered benefits, one very important part of the coverage is what are the services and the items that are covered. And under ACA plans, they have to cover the essential health benefits, including preventive services, which are 10 general categories of services that are in the law. And then they may include additional benefits depending upon how the insurer designs the plan. The plans also have a provider network, a network of healthcare providers. So that is when insurers contract with physicians, hospitals, or other healthcare providers who are actually providing the services to the plan enrollees. The network in a given plan could be really broad, that with a lot of different types of providers and a lot of different specialties and categories. Or the network could be narrow, meaning it doesn't have as many providers in the different categories. And the plan, depending upon how the insured has designed it, may provide some coverage outside of its network, or it may not provide coverage out of this network. When that happens, and we'll talk more about this, the person that's covered in the plan has to pay the costs that they get outside the network. So the essential benefits, these are the 10 categories that I mentioned. These are kind of general categories, and there's more specific rules and standards that have to be met within these, but this is just to give you a general idea. The plans have to cover pretty much everything you can think of as being part of your normal healthcare needs. So emergency services, hospitalization for people who need it, pediatric care, prescription drugs, maternity and newborn care, mental health and substance use disorder services. All of these categories have to be included in the plans. And then there's cost sharing when people use those services. So the plans typically have a deductible, and that's the amount that the enrollee has to pay each year before the plan begins to pay for most of the benefits. It's a yearly amount, usually the biggest number that you see when you're looking at a plan. Co-payments are a dollar amount that somebody might pay when they go to the doctor. So that's like a $25 co-payment that you would pay if you go to the doctor, or a $50 co-payment if you go and get a prescription filled at the pharmacy. And sometimes the co-payments are applicable before a deductible is met, meaning that the person doesn't have to pay the whole deductible amount for certain services. Sometimes the co-payments are applying before that. And then there's also co-insurance in some of these plans, and that is a percentage rather than a dollar amount of the cost of an item or service that enrollees must pay. So for example, 30% of the cost of a doctor's visit or 50% of the cost of a hospitalization would be a co-insurance amount. Another important feature of these plans, particularly for people who have very high cost needs when they're using one of these plans, is the maximum out-of-pocket limit. This caps the amount that the enrollee has to pay every year in cost sharing charges. So it applies based on, each year there's a new out-of-pocket limit under the plan, and it applies to in-network services, but not out-of-network care. There may be separate ones for out-of-network care, but this one is for in-network services, and it's really helpful for people who are staying in network. Make sure that they don't pay too much in deductibles and co-payments and co-insurance during the course of the year. Just in case, because sometimes people are confused, the out-of-pocket limit is not the amount that an enrollee has to spend each year. It's really a cap. And very, very few people reach anything close to these caps typically. So that's important to know, but it's really a backstop, particularly when people are hospitalized or face other very expensive health care needs. So for 2019, and this is actually set as a federal requirement, all the plans have to have an individual out-of-pocket limit of $7,900 per person per year. That applies to every individual in the plan. That's the maximum amount that a person can be asked to spend out of pocket per year under their healthcare plan for covered services. And then for a family, the maximum is $15,800 for 2019, but it's really important to note that that individual amount does apply to the members of a family. So that is an important protection to keep in mind. For lower income people who are eligible for cost sharing reductions, which we're going to talk in greater detail about later, there's actually lower out-of-pocket limit amounts that are set, and you can see them at the bottom of this slide. For each of the different levels of income, there are lower amounts, recognizing that lower income people would never be able to meet the larger out-of-pocket limit that applies to all individuals. So a couple of other notes on cost sharing charges. Some services, depending upon how the insurer designs the plan, may be exempt from the deductible. So a person who's enrolled in that plan may be able to get first dollar coverage for something. So an example that you might see in the real world is that a plan might provide 2 physician visits and charge the enrollee a copayment rather than making them pay the full deductible amount before getting access to some of the coverage under the plan. Sometimes plans offer coverage of generic drugs with a copayment and don't charge the deductible. And that's helpful. Those are some commonly used services, and that's something insurers do sometimes to help provide some coverage to people before the deductible amount so that they feel like they're getting some value out of their plan. So some of those commonly used services might just require a copayment. You might also see sometimes a separate deductible under a plan, and an example of that often is prescription drugs. There may be a separate deductible that the person has to meet before their prescription drug coverage kicks in. It's kind of to the side of the regular plan deductible. So this is a technical issue, but it's meant to make it simpler for people to have metal levels to label these plans is just a way to try to organize the different choices that are available when people are looking at their different options. So, and we're going to talk about actuarial value in a second, but basically the metal levels are meant to just signal that a bronze plan for that somebody gets is going to have a lower premium and provide less coverage in general. It's going to require higher out-of-pocket costs for the enrollee, while a gold plan is going to have a higher premium but provide much more coverage and lower out-of-pocket costs for the enrollee. So the kind of more precious the metal, the more benefits to the beneficiary, but also the more cost that there is in the premium. So that's just a way to organize it. Most people in the marketplaces are enrolling in silver plans as well as bronze plans. So those tend to be the most popular, in part because the cost sharing reduction plans are all silver, as we'll talk about in a minute. But that's probably what people are going to gravitate towards, but it's worth examining, particularly with people eligible for premium tax credits, all the different options that are available. So what is actuarial value? If you don't feel like you need to know this, you can totally tune it out. But sometimes it's good to understand what those percentages are that are associated with the metal levels I just talked about. Actuarial value is really a technical insurance concept. It's a way to estimate and compare the overall generosity of one insurance plan versus another insurance plan. And the way that it's calculated is that basically an actuary, assumes that the entire population enrolls. That's your typical population over there. Those little faceless people are your typical population. They're a mix of sort of different healthcare needs. Some are expensive, some are not so expensive. And that's sort of considered the typical population. The actuary estimates the percentage of costs that the plan pays for that population's covered services, and then is able to compare that estimate to that same estimate for other plans, looking again at the same typical population. So if a plan pays 70% of the cost of covered benefits for that whole population, then it meets the standard to be a silver plan. And that's the way that we categorize the ACA plans in those metal levels. Sometimes people get confused when they see the percentages that are actuarial value percentages. An AV, so that's what the red box at the bottom of your slide is. The AV, the actuarial value, does not represent what the plan pays for a particular individual who's enrolled in the plan. It's an overall estimate. The enrollee's own out-of-pocket costs are going to depend on what medical care a person uses. That obviously varies a lot from person to person. And also the actuarial value does not determine what benefits or prescription drugs are covered under a plan, nor does it impact the provider network. So those are items that matter to how much people pay that are kind of outside of the actuarial value estimate. And this is just a chart to show you how actuarial value, that technical concept, actually guides how insurers design the cost sharing charges under their plans. So these are real examples of 2018 plans that happen to come from Virginia. And you can see there's a couple of bronze examples, a couple of silver examples. You can see that generally with a lower AV, so a 60% AV with a bronze plan, you're seeing higher deductibles, higher cost sharing, more percentages, in other words, co-insurance for services, which is a little bit less predictable for the enrollee and can be more costly. Those are more common with the bronze plans. With the silver plans, you can see there's at least one option there with a slightly lower deductible. You can see there are more instances of co-payments rather than co-insurance, meaning that there's probably likely a little bit more predictability and affordability in cost sharing for the enrollee. And then the gold plan with an even higher actuarial value has no deductible in this case, lower cost sharing charges overall, and lower co-payments compared to the other plans that you see up there in a lot of cases. So this example is meant to show sort of how cost sharing works during the course of a year. It's a very simple example. That's Carla. We're going to pretend that she unfortunately broke her leg, and she's going to rack up a bunch of healthcare costs. What you see on the screen right now are the basic features of her plan. Again, very simple. We're imagining that she has a $5,500 deductible, that she doesn't have any coverage below that deductible for most things, and that those are the cost sharing amounts and co-insurance rates that she pays for different items that she's going to need once she's broken her leg. So just to flesh this out a little bit, her costs are about $13,000 in this example so far. And at the beginning of the year, right after she breaks her leg, she's paying the full cost of the services that she needs because she's still under her deductible amount. And so some of her hospital bills, some of the other care that she needs, she's going to be paying for out of pocket herself. Once she hits that $5,500 limit, she's going to be paying a little bit less of the charges, right? At that point, after she's reached her deductible, Carla is paying 25% of the cost that she's facing in her coinsurance plus some of the copays. And once she's racked up a little bit even more costs under her plan, 25% of the services that have the co-payments plus $125 in copays, eventually she reaches her out-of-pocket limit in this example, which, as I said, is not super common. But once she's hit a $73.50 limit under this plan, she doesn't pay any more out-of-pocket for in-network care that she needs. So any additional costs she has past that September mark that she's reached, the insurer is actually going to be taking on the costs for the rest of the time. So if a family is enrolling in a plan, the cost sharing amounts and charges are going to look different than they are when an individual enrolls in a plan. So in this chart, you can see that for an individual versus a family, the family is going to have basically double the annual cost sharing amounts. Annual cost sharing amounts are the deductible and the out-of-pocket limit that apply on a yearly basis. Those are usually double for the family. While the amounts like coinsurance rates and copayment amounts for different services are the same for the family members. Another kind of nuanced issue to be aware of with family cost sharing, the ways in which those yearly out-of-pocket costs apply and the way that they're calculated can differ based on the plan's design. And we actually don't know and would love to hear from all of you what is the most common type of cost sharing that you're seeing out there. But this is all just to explain the two different types of family cost sharing. One is embedded and one is aggregate. With embedded family cost sharing, you can see there with an embedded deductible and an embedded out-of-pocket limit. With the deductible, in addition to a family deductible, there's individual smaller amount of deductibles that apply to each family member. And similarly, with the out-of-pocket limit, there are smaller individual out-of-pocket limits that apply to each individual, even though, as we saw on this last slide, the overall out-of-pocket limit and the overall deductible for the family plan is larger than it is for an individual. And then with aggregate family cost sharing, all the family members' expenses are pooled toward a combined family deductible. And with an out-of-pocket limit that's in aggregate, all the family members' expenses are pooled toward a combined out-of-pocket limit. So with that type of deductible, aggregate deductible, there could be a family deductible where basically the plan isn't paying for most benefits until that deductible, that family amount is reached. Whereas with the embedded, there are smaller deductible amounts where for each individual family member, some coverage might kick in. So the little red box at the bottom is just to note again that even if family members are on a plan together and even if there's aggregate cost sharing with a rather large deductible or out-of-pocket cap, no individual member of the family can be charged out of pocket for in-network care any more than the limit that's set for that year. So for 2019, that limit is $7,900. And as we noted before, if the family is eligible for cost sharing reductions, that amount may be lower and no individual member can sort of be hit with a larger amount just because they're a member of a family. Another important distinction with these plans, depending upon the plan design, is that, as I mentioned before, some may have out-of-network coverage and some don't. And in some cases, if there is out-of-network coverage, the out-of-pocket cost is going to look different than it does for in-network coverage. So if the person, for example, with Plan A that you see on your screen is using in-network healthcare providers, you can see that their deductible is lower than it would be $5,000 compared to $10,000. Than it would be if they were using out-of-network healthcare providers. Similarly, they have that out-of-pocket cap protection on their in-network healthcare provider use, whereas in that Plan A example that you can see at the top, they're out-of-network. There is no annual out-of-pocket limit on their out-of-network care, which means if they go out-of-network, they could pay a lot more money out-of-pocket. Co-insurance rates may be different, as you can see with Plan A and with Plan C. Plan B that you see there is an example of a plan that doesn't have any out-of-network coverage. So if a person doesn't use the network, they're not going to get coverage and benefits kind of back from that insurance. And then Plan C is a little bit more complex design that is actually quite common. It's called a tiered network, and you can see that there's tier 1 providers are the very cheapest in terms of the out-of-pocket costs that the enrollee has to pay, but that it varies, and there are different levels of networks that people can decide to use. Not only, I think it's important to note, not only might out-of-pocket cost amounts vary for people depending upon whether they use in-network or out-of-network care, but also with out-of-network care, people could be subject to something called balance billing. Basically, when a healthcare provider is in network for a plan, that means that they have accepted what the plan will pay for a service as their full payment, and they're not going to balance bill people extra amounts if they're in network in that person's plan. But if you're out of network, then the healthcare provider may charge you a higher amount on your bill, and because you're out of network and the provider hasn't agreed to take the payment that your insurer is offering as full payment, then the consumer, the enrollee who's using that service, would have to pay the difference. That's the balance. That's why it's called balance billing. And so you can see on this slide, the plan features of Plan A are just up there as a reminder. There is out-of-network coverage in that situation. But as you can see in the example, in the purple boxes, if you use a network physician, the plan allowed amount of $100, which is less than the doctor's bill of $200. The plan is paying $75 and the patient's paying their copay of $25. Basically, that shows that with the network physician, the plan allowed amount is considered full payment. In addition, what the consumer is spending on that doctor visit counts toward their in-network out-of-pocket limit that we've been talking about. So if they happen to have a lot of expensive care, that is gonna count toward the cap of what they have to pay out-of-pocket that year. On the right-hand side with the out-of-network physician, you can see that the doctor's bill of $200 actually applies in this case because the physician's out-of-network and the plan is not, and the physician is not agreeing to take the plan's allowed amount as full payment. So in that case, in addition to being balance billed, the patient has to pay a higher rate, a higher amount towards the care to begin with. So they end up paying a lot more, $150 compared to if they had gone in network paying $25. So that's all to say with these plans, with any plan, but with these plans in particular, it's worth understanding how the network works, making sure that consumers understand that they face higher costs if they go out of network. So now to move on to cost sharing reductions, which is very important to lots of folks that are enrolling in marketplace plans. Cost sharing reductions, or CSRs, as you might hear them called, they're a federal benefit that reduces the out-of-pocket charges an enrollee pays for medical care covered by the plan. People are eligible if they have incomes up to 250% of the poverty line. And in order to access this benefit, they have to actually enroll in a silver plan through the marketplace. It's not available with the other metal levels, and it's not available outside the marketplace. So that's really important for people to know. And the table below just shows you there the difference in out-of-pocket limits and the fact of the different income ranges, different CSR levels that people are eligible for. So above 250% of poverty, they're going to get a standard 70% silver plan with the standard out-of-pocket caps that we've been talking about. But at lower income levels that go toward the right, they're going to get higher actuarial value plans that translate then into lower deductibles, lower out-of-pocket charges, and lower caps so that if they do have catastrophic health care, they are protected from really, really high costs. So just to explain a little bit about how that works, in order to raise the actuarial value of the plan, this is just Plan A here, silver plan, they're all the same plan, but the insurer actually has to design different versions of that plan so that people who are at the CSR levels can actually enroll in a new version that has a lower deductible and all the other lower out-of-pocket costs. And the insurer has to design it to hit those higher target AVs that you see in the light blue row. So you can see the standard plan is on, with no CSR is on the first column there. And then those at other income levels, when a person enrolls in that silver plan, they're gonna get a lower deductible. So a person over 200% of poverty is going to get a deductible of $3,500 instead of $4,650. A person who is under 150% of poverty, if you go all the way over to the right side of the slide, they're going to have a deductible of $300, which is a lot lower. Not easy for a person under 150% of poverty to pay by any means, but a 94% AV plan is a very good plan and definitely a good reason to make people aware of the cost sharing reductions and the need to enroll in a silver plan if they're eligible. So here's another example of a plan that has been sort of modified to provide lower charges to people who are eligible for CSRs. And the important thing to know also is that people don't have to actually do anything other than enroll in a silver plan. This is what they will see. If you are a person, in this case, who enrolls in this plan, Plan B, and you're at 100, you're over 150% of poverty, up to 200% of poverty, you're going to get a plan that has an $800 deductible, and you will pay no more out of pocket for your in-network care than $1,700 a year at the very most. So another feature is that even for people with CSRs, the cost sharing amounts can be different, right? And that's really just because the actuarial value standard is not that tight of a standard. And there's a lot of different ways for insurers to design their plans to reach that target. So some might choose to reduce the deductible by more than others, as you can see happened in this case. With a 94% AV plan, Plan B has a $250 deductible, whereas Plan A has a $300 deductible. Plan B also has a much lower out-of-pocket cap. But then Plan B has higher coinsurance rates for some of the services. In this table, you can see generic drugs are going to cost more than likely, and also specialty drugs have a higher coinsurance rate. So certain services will cost people more. Deductibles may be different depending upon which plan a CSR eligible person chooses. So they too have to be aware of the cost sharing under their plans. You've probably read in the news that the federal government terminated reimbursements to insurance companies for the CSR plans. So we wanted to just provide a little bit of information about that. The important thing is that people who are eligible for CSRs continue to be eligible for that assistance, and they can continue to enroll in plans with reduced cost sharing charges, including in 2019. The plan designs for the CSR plans are not affected by this change. So everything I just explained about what the designs look like continue to be the case. The issue of the termination of the payments is really a matter of how the insurers are being reimbursed, and it's really not something that the consumer should be dramatically affected by. They shouldn't see hugely different designs in their plans and that sort of thing. To cover the cost, and this is just to explain why that's the case, to cover the cost resulting from the termination of the CSR payments, insurers generally increase their premiums. Most often, depending upon the state and what the state told them to do, insurers loaded the costs that they wanted to be reimbursed for CSRs onto the premiums for silver marketplace plans. That's a technique called silver loading, which is a term you may hear when you read about this or hear about it on the news. So because the premium tax credit calculations are tied to the silver plans, the premium credits amounts rose with premium increases. When the insurers raised their premiums to account for the loss of CSR reimbursements, the premium tax credits also were larger. Silver loading led to much higher unsubsidized marketplace premiums for silver plans relative to premiums for bronze or gold plans. So for unsubsidized people, they're going to see very high silver plans in a lot of cases. In many areas, the unsubsidized premium of the lowest cost gold plan in 2018 has a comparable cost to the lowest cost silver plan, and bronze plans can be near zero cost after the premium tax credit is applied. So it's good to just know the metal levels are there, that this fact of CSR reimbursements being terminated has affected the array of choices in terms of what might be better for a consumer. It's still really important to emphasize for CSR eligible people that silver plans are the way to go. But there may be cases where people really want a low premium, and if they can get a $0 bronze plan after their premium tax credit, that might be worth considering. Sometimes unsubsidized people or people at the higher end of the subsidy range who aren't eligible for CSRs have been able to get really good coverage under a gold plan and not pay that much for it. So it's just worth paying attention. This varies to some extent and what's going on in your state, but know that that's happening, that you can reassure people about their access to CSRs and not get too nervous about that aspect of this issue. Under the ACA, there is special assistance, special cost sharing help for American Indians and Alaska Natives. So if you live in a state where there are large populations of American Indians and Alaska Natives, this is especially important to be aware of. For federally recognized Native American tribes and Alaska Native Claims Settlement Act corporation shareholders, that's who this applies to. Those folks can enroll in or change marketplace plans each month. Most people don't want to do that, but it's a flexibility for people who've missed the open enrollment period, for example, if they meet this standard. For American Indians and Alaska Natives who are between 100% of poverty and 300% of poverty who qualify for premium tax credits, they can actually access zero cost sharing plans under which they pay no deductibles, no co-payments, or other cost sharing when they use in-network medical care. And some out-of-network care is also available with zero cost sharing. So that's a really important benefit for people to be aware of if they're eligible. Also, for people with incomes below 100% of poverty or above 300% of poverty, so different range than the earlier bullet, there are also limited cost sharing plans available. And under those plans, the enrollees pay no cost sharing charges if they receive services from an Indian health services provider or from another provider if they're referred from an IHS provider. So good to be aware of, good to inform people about when they're looking at marketplace plans. All right, so Skimpy plans.
And we're actually going to stop for some questions, I think, first, just to do a few questions, because this is sort of, this is going into, you just learned about compliant plans.
Yes.
So we'll answer some questions about that, and then we're going to talk about non-compliant plans for the rest of this presentation. But one thing that this always comes up, and it's incredibly confusing, but how some of these cost sharing charges are nestled within each other, and with deductibles, the deductible counts towards the out-of-pocket.
Yes.
Co-pays count towards the out-of-pocket. Co-insurance counts towards the out-of-pocket. So everything that you pay counts towards the out-of-pocket if it's if you're going in network.
Yep.
But one thing to note is for the deductible, those co-pays that Sarah mentioned that you can get before you've met the deductible. So it's called first dollar coverage sometimes. Pre-deductible is also used. So if you get the plan and before you've paid any cost sharing charges at all, you can go to the doctor for a $25 copay. That amount is not going to count towards the deductible because it is sort of pre-deductible, but it is going to count towards the out-of-pocket maximum.
Yep, probably.
Yeah.
Yeah, but it always counts for the out-of-pocket maximum.
It always counts.
Yes.
Yeah, it always counts towards
Exactly.
the out-of-pocket maximum. So that's something, I know that is a lot and very confusing.
And sometimes a good thing to do, and I know we'll do other webinars and have other materials that speak to this, but a good thing to do if this is something you're trying to find out about a plan is to look at the summary of benefits and coverage document, which is supposed to explain this in a standard way across plans. So it should detail for you if a person wants to know, for example, how many physician visits can I get for a copayment? Do I have to pay this deductible before I get any prescription drug coverage? That's a document where that information should be conveyed by the insurer very clearly and standardized. So you can say, well, this plan, you know, your generic drugs are covered below the deductible for a $10 copayment. And on this plan, actually, you have to meet your $3,000 deductible before you get any drug coverage. That's going to be really helpful information for people.
Yeah, and relatedly, with deductibles versus sort of out-of-pocket costs, the deductible is the amount someone needs to pay before the plan starts paying part of the cost sharing. And the out-of-pocket is sort of that limit. Once someone hits that, they don't have to pay anything for the rest of the year. So the deductible, some things are pre-deductible, so you might get some coverage before you meet that. But once you meet the deductible, the plan doesn't pay for everything. It just starts they start paying for some things. It kind of
right. Yeah. So like back to our example with Carla, she reaches her $5,500 deductible in this case, and in this case, she's not getting much coverage before she meets that. It looks like she has a few copays there. Maybe she had some physical therapy that was covered below the deductible. But then she's still throughout April, May, June, July, August, paying a portion of her costs while her insurer is paying other parts of her costs. So she's either paying co-payments that you can see up on the chart above, or she's paying percentage, the co-insurance percentage of 25%, while the plan is paying the remainder. And so she's doing that. She's paying that portion with the insurer kind of sharing in that cost until she hits the health costs, in this case of the out-of-pocket limit of $73.50 for the year. And that is when she's not paying any more cost sharing and her plan is paying the rest.
And then on the out-of-pocket limit, there is every year there's sort of a standard limit that is the maximum out-of-pocket limit, and that does change every year. So last year it was lower, this year it is higher, and so that's something to be aware of, is that limit does actually change, but plans don't have to have that limit as their highest out-of-pocket limit. It can be lower than that, even if they're it depends on how they're sort of shifting costs. So you'll see plans that have it's just sort of a cap on what they could have, but it does not mean that they have to have that as the out-of-pocket limit.
Right. They're setting that and meeting their actual value target, and they may do that in different ways. So if they decided to set a lower out-of-pocket cap, that's totally within the rules.
And then this one is a little difficult, but how do you tell if a plan has an embedded or an aggregate family cost sharing within the plan?
I have sometimes seen that information in plan marketing materials. So like the brochures that insurers have may explain that when they're explaining the cost sharing or when they're explaining family plans. The insurer should be able to answer that question if you want to know it, if you know what plans are going to be available in your area before November 1st, and you want to make a couple phone calls if there's 2 or 3 insurers that you want to ask to make sure that you understand. I would also go again to that document, the summary of benefits and coverage. It provides a lot more information about things, the details of the plan. Sometimes it may be available in there, but I think it's really notoriously hard information to find. I think our guess is that most of the time there are going to be embedded deductibles for family members just because of the way the cost sharing rules work, but we don't actually know that to be true. And if a plan, for example, is a health savings account plan, they may be more likely to have an aggregate family deductible in order to meet the HSA rules. So hard to know. It usually doesn't make a huge difference for a family unless they have one or more members of the family that do have significant healthcare costs. So I think that's when you want to dig in and know the details, when you know that you're dealing with a client where this is really going to matter. And I think just as like a consumer information standpoint, it's good for people to understand how their plans work. But if you can't find it in the plan documents, it's going to take a call to the insurer or a broker who works for that insurer to explain what they're able to find out.
And then we're going to take 2 more questions right now, but then we'll do more questions at the end of the presentation. So one is a short one. Are in-network costs that go towards an in-network deductible and costs that go towards an out-of-network deductible, are those separate costs? Like can costs going towards the in-network deductible go towards the out-of-network deductible, or do you have to meet them separately?
They are separate because care can't be both in-network and out of, a service that's provided isn't in-network and out-of-network at the same time. It's either in-network or out-of-network. So if you go to a doctor that's in-network, that is going to be under the column of in-network cost sharing. That's going to go toward your in-network deductible. It's going to, the copayment or coinsurance for in-network care is going to apply to that. And then the out-of-network, the out-of-pocket cap for in-network care is what's going to apply and what that is going to count toward. Think of the out-of-network care use as kind of in a separate column. You have maybe a separate deductible, separate out-of-pocket cap, and that's going to be kind of accrue totally separately, depending upon if the service or the item that you're getting coverage for is in-network or out-of-network.
And then what happens with your cost sharing charges if you're in a cost sharing reduction plan, and let's say you're in the 87%, and then you shift to a different level of cost sharing reduction. Mm-hmm. Their income changes, but you don't change plans. How does that cost sharing work throughout the year if you've already paid into the plan?
Yeah, that's a really good question. So, that does happen obviously as people's income shifts during the course of the year. The rules are that the insurer is obligated, once that person has reported that change in their income, the insurer is obligated to put them in the correct CSR plan. So they should automatically be moved into, in this case, if they're going from 87 to 94, I don't remember what you said. So if they're going from 87 to 94, then the insurer should be making that adjustment. And the annual cost sharing amounts that we've talked about, so the deductible amount and the out-of-pocket cap amount, those are obviously going to be different in the new plan, right? They're going to have a lower deductible, they're going to have a lower out-of-pocket amount, and they may very well have used care, which is the point you're making. In the meantime, any care that they've used, those amounts that they've already paid for that care are supposed to accrue toward their new deductible and toward their new out-of-pocket limit. So if they've already spent $300 that year and their new plan has a $300 deductible, they should be past their deductible, and the plan should be covering those costs. So those are in federal rules. We get asked this question a lot. It's a confusing thing because it doesn't always work the way that it's supposed to work. So we're always sending out this language in the federal rules, but this is something that definitely, if it comes up and the person isn't getting what they're entitled to, that's something to press with the marketplace and with the insurer and remind them of the rules. Because yes, people are definitely supposed to get credit for what they've already paid toward their deductible and toward their out-of-pocket limit, and the new one applies. So that's important to know.
Perfect. And again, we have one more section to get through, so we'll do more questions at the end, and we'll probably stay on a little bit longer to answer some questions. So again, if you have a question, you can just type it in the Q&A boxes. You can click on the little icon at the bottom of your Zoom screen, and then you can type in questions, and we'll be monitoring them throughout, and then we'll try and answer as many as we can at the end. So take it away. We'll go on to Skimpy plans.
Yeah, so basically everything we just talked about, forget it. No, again, hopefully people will not be interested in these plans, and they will be ready and willing and able to enroll in ACA-compliant plans. But the reason that we wanted to talk about plans that don't meet ACA standards, we're calling them shorthand Skimpy plans on this slide, but we can think of a lot of names for them. The reason we're talking about them, why it's important to be aware of, is that because of federal rule changes, because the federal government and some state officials are promoting non-ACA compliant plans as a really good alternative to ACA plans for tons of different types of people, that is really emboldening the companies that offer a lot of these plans to do more marketing, to really try to sell their plans, including to try to sell their plans during the ACA open enrollment period, even though there is no open enrollment period for these plans that we're about to talk about, right? These are plans that can be sold at any time, but the energy and the interest that open enrollment generates, it's going to be capitalized on by the companies that sell these other kinds of plans because they want to sign people up, they want to make money. So I think your clients, the people that you're helping, are likely to be seeing marketing information about these plans. We know marketing can sometimes be very aggressive, robocalls, internet ads, emails, all that sort of thing. They may be getting that information from the same insurers that offer ACA plans, depending upon what's happening in your state. Consumers may need information about how these plans differ from ACA plans and kind of what the drawbacks would be. All right, so what are we talking about when we talk about skimpy plans? The significant thing about them is they may be exempt from some or all insurance market standards and consumer protections that apply to ACA plans. So some of these plans, and we'll dig into the details of this a little bit more in a couple of the next slides. Some of these plans can charge higher premiums because of people's age, gender, health status. Some may deny plans to people based on their pre-existing conditions. Some may cover people with pre-existing conditions, but deny the claims that relate to their pre-existing conditions. And some may not cover certain essential health benefits. So some of the plans that we're talking about here are, number one, short-term limited duration plans, short-term health plans. Sometimes they're called STLDI for short. We're going to spend a little bit of time talking about those today because those could be particularly popular or commonly seen. Association health plans also have been expanded to cover more small businesses and self-employed people and to form more easily so they could be more active in the coming months. Healthcare sharing ministries are something that's been around, as have the other types of plans. But because this is kind of a bonanza time for non-ACA plans, you may see more activity around healthcare sharing ministries. And other types of indemnity plans or combination or bundle products. So I'm just gonna quickly define a few of these, and we're gonna talk more, as I said, about short-term health plans. They're basically, those are plans that are basically meant for short gaps in coverage, and particularly before the ACA came along, when it was harder for people to get into the individual market, or it was more complicated to get into the individual market. This might be something that people bought for like their college kid that was graduating, or if they lost their job and they were between health insurance from their job. But those are exempt from most individual market rules in most states. Association health plans are plans that are offered by trade and professional organizations to their members. So like a chamber of commerce or a realtors association might offer these plans. Because of some of the rule changes, they'll now be able to be treated as large employer plans and subject to large group rules, even if they're sold to individuals and small businesses. So basically lesser protections and consumer benefits than, but possibly under those plans, than would otherwise be available if the individual or the small group was buying in the individual market or the small group market. Healthcare sharing ministries are not health insurance. They were initially sort of a way for people that are part of a religious group or community to share their medical expenses. But that has broadened a lot and become, frankly, a lot more corporate. And now sometimes you see brokers selling these the ministries, even though they're not really plans, and really actively marketed beyond small religious communities into the broader population, and even in some cases sold to people based on ethical ties rather than religious ties. And in those arrangements, people typically pay in a monthly amount, but pre-ex conditions are often excluded. They often have morality clauses, so people can't get birth control, or if they're not allowed to drink or do any illegal drugs, and certain services might not be covered. Basically there's a dollar limit, and there's no real guarantee most of the time that your expenses are going to be covered when a disaster hits. So it's really not insurance. But people may be shown this alongside insurance, depending upon what the marketing looks like for these plans. Some other types of non-ACA plans that exist and that you could see more frequently. One is indemnity plans or fixed indemnity plans. In those plans, the insurer pays a set percentage or a set dollar amount for specific services, and the enrollee pays the rest of the bill. So an example would be a plan that gives you $200 if you have to go to the hospital, or $100 per day if you're hospitalized. It's not taking on even the majority of the costs of a person that needs those benefits. It's really just paying you a defined amount. and then the bundled products, a bundled product or insurance package is something that like a broker might put together, a web broker might put together, or an insurer might be offering. And it's a combination of different types of some of these plans that we're mentioning. So it could be like a hospital indemnity plan. So covers you for if you're hospitalized, and maybe gives you a drug discount card. Maybe it's a short-term plan plus dental. Maybe it's indemnity plan where the consumer picks which benefits they want. So maybe they want hospital and office visits, but then they don't get anything else. And it's all dollar limited on how much they get per day or per illness, unlike the ACA plans that we were just talking about. So this is a chart, really, I'm not going to go through this slide or the next slide. I just want you to have this as a reference point. We thought it was useful for you to hang on to if you really wanted to understand the differences between these different types of plans in terms of what rules apply to them. Your state may have additional protections or vary somewhat. So it's not like every state is the same. Some states don't allow short-term plans to be sold. Some regulate them more strictly than the federal rules do. But most don't. So it's important to just know that these plans may be out there, and if they're out there, they may not be subject to the same protections and standards that ACA plans are subject to. So you can see there in the ACA plans column, they're guaranteed issue. They have to be provided to people regardless of health status or other personal characteristics. Rating requirements, ACA plans can't charge more based on gender. They're limited on how much they can charge based on age. They have to provide that SBC, that document that I mentioned before. Whereas these other plans often don't have to meet any of those standards. Here's another chart, and this is really thanks to the paper that's linked to at the very bottom. If you want to read more about this, that's a really good resource. So you can see here, the ACA plan has to, it cannot have pre-existing condition exclusions or short-term plans, and sharing ministries obviously do that. That's a prime part of how they're designed usually. These other types of plans don't have to cover the essential health benefits. They don't have to meet those minimum actuarial value standards that we talked about. They don't have to be bronze, silver, gold, or platinum. They could be less than bronze. Or they could be totally different AV levels. They're not subject to those requirements. They may have annual, these other plans may have annual and lifetime dollar limits, and may not cover preventive services without cost sharing like the ACA plans have to do. Now, we wanted to talk a little bit about short-term plans, a little extra, and why is that? I think it's possible, well, we're already seeing a lot of aggressive marketing around short-term plans, and you may be too. Your consumers that you're working with may be as well. And I think because the federal rules now allow short-term plans to be last less than 3 months. They used to be limited to 3 months, and now they can be up to a year or even be renewed in most states. They're going to look a lot more like a regular health insurance plan than they used to, and that is definitely how the consumer may view them. They have a lot of the same features as a regular health insurance plan, and it might be hard for people to distinguish between them. So as of October 2nd, which is coming right up, that's when the federal rules change and these plans can last for longer than 3 months. States retain the authority to limit and set standards, and we'll talk a little bit more about that. But in most states, the federal rule is what's going to apply. Some states may have a 6-month limit. They may have other consumer protections. Some states have past 3-month limits, but maybe not. The risk of short-term plans is that healthy people who enroll in them may find themselves facing gaps in coverage, and could be exposed to high catastrophic costs if they get sick and end up needing care. So that's the concern. It also doesn't count as minimum essential coverage. So when the plan ends, it doesn't trigger a special enrollment period. So if people have been confused and didn't really understand what they were getting or when it was over, when it was going to end, they may find themselves between ACA open enrollment periods and without coverage other than a short-term plan, which maybe they can extend it under these new rules, but only if the insurer says they can. The short-term plans, as we mentioned, are exempt from most standards. They can deny coverage to people that have pre-existing conditions if they decide to. The insurers, even if you got a plan, the insurer could exclude, and the plans typically do include broad exclusions of pre-existing conditions. So if you have a pre-existing condition and then you try to get coverage for like your diabetes drug, your claims are going to be denied because you have a pre-existing condition. So the things that you need are not going to be covered. It is also a fact of life that once insurers can consider pre-existing conditions in this way, they engage in post-claims underwriting, where they may, if they see somebody has filed a large claim that maybe should be covered, they will investigate the health history of an enrollee in order to find prior care that they might have had or symptoms that they complained about, and to try to link that costly claim that that insurer is supposed to be on the hook for to a pre-existing health condition. Even if the link is tenuous, people have run into problems with those situations. And this may vary by state, but sometimes the insurer may be able to consider a condition pre-existing even if it wasn't diagnosed before, even if the person didn't get treatment for it, and even if the person wasn't aware of it. So it's really a way that the consumer can kind of get caught in the crosshairs when they're sick if they have one of these plans. Short-term plans are also not required to cover the essential health benefits, and we know they often don't cover the ones that are listed here. They can also impose limits on plan benefits, lifetime dollar limits, per service limits like indemnity plans, and all of those basically shift the cost of any health care that person needs to the consumer. So the plans might appear similar to ACA plans. As you can see here, this doesn't look all that much different than a healthcare.gov website. And the plans have many of the same features as a regular health insurance plan. They have a premium, they have a deductible, they have a coinsurance amount, they have a maximum out-of-pocket cap. So people might not realize at first blush what it is that they're dealing with. Same here, deductible, coinsurance. It might seem very much like a regular health insurance plan, even though it's very different. So even though they have those features, deductibles, maximums, copays, you may face very significant limits. We put a lot of fine print on these slides because we wanted people to know that there is a lot of fine print. These are some examples of those pre-existing condition limitations that I mentioned. These are examples of missing benefits, essential health benefits that aren't covered. Because these are not plans that have to cover essential health benefits. And then there might be limitations on benefits that you can see here, dollar limits in this case, as we mentioned. Again, a lot of fine print. Get out your magnifying glass, but this is just to give you the volume of specific exclusions that might be in these plans that the consumer definitely is going to be aware of on first glance. So hazard activities might not be covered, snowmobile skiing accidents, sports activities, self-inflicted injuries, things that happen when people are intoxicated or under the influence of illegal narcotics may all be excluded when the time comes to get that care. They may have waiting periods. The good news is that some states have acted to shore up the market and to protect consumers from short-term plans. As you can see here, 3 states recently enacted protections. Those are in stripes. And the red states already had protections that ban the plans or had, 3 months or less of coverage, which helps to limit how many people have these plans. So what can you do about these plans? I think this is just a slide to remind you that, consumers definitely need information to help them understand open enrollment and the deadline for ACA coverage. That really is a deadline to see past low premiums when they get shown a short-term plan or another type of skimpy coverage so that they can understand what the gaps would be. It would be great if people were more aware of special enrollment periods. I know you all work very hard to do that. If people are having a short coverage gap or a long coverage gap, we should be helping them understand that ACA coverage is available in a lot of those circumstances. And then looking for and tracking what it is that consumers are getting, reporting information to local regulators if you do see fraud or misinformation, and helping consumers to lodge complaints if there is wrongdoing. Those can all be helpful things as we try to get a handle of this situation and prevent the market from becoming a Wild West.
So we have a bunch of resources up here, and I know you guys can't actually click on any of these links, but we will send around the slides. There should be a link to the slides in the chat box, but we'll also send it after the presentation, and it'll be posted on Beyond the Basics, Health Reform Beyond the Basics.org right after this presentation as well. And we'll have a video recording that will be posted too. So I know that we are over time, but we'll stay for a little bit and answer a few questions because you guys have some really good questions. One sort of a general thing, someone asked how assisters are supposed to explain these plans to people in simple terms, because it is incredibly complicated, and trying to sort of convey so much information if there's ways to do that. And we are going to have a webinar on Tuesday, September 25th at 2 p.m. Eastern. And that's going to go into some of the strategies of talking to clients about these plans and sort of helping them focus in on what are their top priorities and how to kind of look for that within these plans, because it seems overwhelming with all of this information and where you're even supposed to find it. So I'm not going to say that it's going to be easy, but it will give you some tools and some strategies to try to make it more manageable. So that's something we completely understand how complicated all of this is. Even for the compliant plans that actually cover things, it's still really complicated. And so hopefully we can kind of at least help with some strategies. So back to Skimpy plans. Will the marketplace be showing people these plans side by side with ACA plans?
No, that is against the rules. So that's good news. When people go to healthcare.gov, they're going to see QHPs, qualified health plans, that meet ACA standards. So that's very good news. Some of the entities that do direct enrollment in your state, like if an insurer does direct enrollment through the FFM or enhanced direct enrollment, where they're helping people kind of through the whole process, web brokers sometimes do this. They're not allowed to do it either. They're not allowed to show you a short-term plan alongside a QHP, but some of those entities that do direct enrollment also sell those plans. So they may, at some point in the process be showing those plans to people. But if a person is shopping for ACA plans, qualified health plans, those direct enrollment providers are also not supposed to be showing them side by side. So it's tricky. We're worried about that, but I think the good news is, to your point, that healthcare.gov is still safe.
And then someone asked, and we kind of want to reiterate this because it, again, is confusing. But can any of these sort of short-term plans, Skimpy plans, be dropped at any time, and then can you enroll in a marketplace plan? Is that possible? And essentially, if it's open enrollment, yes. Any other time though, if you drop that plan and it's not open enrollment and you're not eligible for some other type of special enrollment period, you're not going to be able to just get into the marketplace. So that's important to remember.
Yeah, and if you were, for example, if you saw somebody who had signed up for a short-term plan, let's have that scenario for a second, but they lost their job 30 days ago or 50 days ago, less than 60 days ago, they're still in the SEP window. So if they've just done something that is a mistake and they're still in their special enrollment period window, you can definitely fix that. And that is good news. People are going to be told that these plans are for people who are between jobs. And if the person is beyond that 60-day special enrollment period window, they can't, as Hallie said, just go and enroll whenever they want in an ACA plan. They would have to wait until the next open enrollment period. So that would be November, and then their coverage would start the next January. So that is the concern, is that people will end up wrongly enrolled or mistakenly enrolled or not understand what they've enrolled in. So look for a qualifying event and see when it happened, and you may be able to fix some of those mistakes.
And then do you have any advice on ways to find out from your specific state what the rules are in place in your state on sort of these Skimpy plans?
Yeah. So this slide that you see now with the map on it, the link at the bottom of that has some more details. The basis for that map is linked to there. I'm not sure if it's on our resource page, but we can send it out. We have a chart that was put together by the folks at Georgetown Center for Health Insurance Reforms that tracks that in more detail. It's before these recent changes, but it might be helpful as a reference for your state. So we can definitely get that around so that you can look on a chart and see what is the status of short-term plan protections in my state.
And then let's see. Okay, going back to ACA compliant plans. Should the deductible and out-of-pocket max sort of cost sharing charges that you've already paid into a plan, do those start over if you have two people in the plan and one person, the sort of primary person, leaves the plan for whatever reason? They are eligible for Medicare, so they leave the plan, but the other person who was in the plan stays in the plan. Do those cost sharing charges start over? Or if they're in the same plan, do they still get credit for cost sharing already paid?
So if the person leaves and they're in an individual, and the person that's remaining is in an individual plan, they're going to be in an individual plan subject to individual cost sharing, but whatever cost sharing that they have accrued should still count for that year. So again, it's an issue of holding insurers to that and making sure that it does work out that way, but that is the way that it's supposed to work. And I also wanted to note, to back up to the last question, we do actually have a link to the paper that I'm talking about. So on your resources page, if you look at the very bottom, the state regulation of coverage options outside of the ACA, there is a table in that paper that goes into more detail about short-term plan restrictions in various states. And if you want to email us about your state, we can help you look it up.
And then we'll do one more question because I know it's quite a bit past. But for going way back to silver loading, so the termination of cost sharing reductions and this silver loading concept, did that already start, or is that starting in 2019?
It already started. It happened last year. So if you were working in this space last year and dealing with cost sharing reduction plans, it didn't happen before open enrollment for last year's plans, right? But it happened during the course of last year. No, it happened before. It happened before. Sorry, yeah. Time is funny. No, you've already dealt with this. So in most states, silver loading happened. It wasn't the case in every single state, but most insurers did it this way. And so it's probably not going to be new. And that is really the message we wanted you to take home for 2019.
And then again, you guys have great questions. So if your question didn't get answered, if you have additional questions, please feel free to email us. You can email that Beyond the Basics general inquiries email, or you can email myself or Sarah, and we'll answer sort of as many questions as we can, or point you in the right direction. So please email us. Couple of words in closing. Just as a reminder, we're going to be distributing all the materials from today's webinar, both the slides, a video recording, all of these resource links. We'll get them all to you. We've already had 2 parts in this series, and we will have those videos up later today or tomorrow morning, so you'll be able to review that information. Our next upcoming webinar, which I mentioned earlier on sort of plan selection strategies, that is scheduled for next Tuesday, September 25th at 2 p.m. Eastern, 11 a.m. Pacific. And that is actually going to be presented by Dave Chandrasekaran, who is a training consultant working with CBPP, who sort of specializes in this space. So he'll be our special guest presenter on that webinar. We also have a webinar on Thursday on the auto renewal process, and that will be at 2 p.m. Eastern as well. And then we have additional webinars starting on Thursdays in October. So you can get all of that information on our Health Reform Beyond the Basics website under upcoming webinars, and we'll send out lots of reminder emails if you are on our Beyond the Basics list. If you would like to be added to our Beyond the Basics list, you are welcome to email me and I can add you. So again, please go to that Beyond the Basics website, there's tons of resources and webinars and all sorts of different things for you all to use. And if you see something that is missing, if something that you just can't find and you would like to have a resource on it, email us, let us know, and we will try to create something. We know how complicated all of this can be, so anything that we can do to make your life easier, please let us know. Again, if you have any questions, need assistance going forward, please email us. And with that, we're going to bring this to a close. So thank you so much again for joining us today, and hopefully we'll see you next week. Thank you.